here have done phlebotomy before? Is this new to all of you? So a couple of you have done it. Okay. Many of you are terrified of it. Okay.
Thanks.
Don't be afraid. It's hard getting over those first couple sticks, but once you do it a few times, it's not so bad. And you just have to remind yourself that what you're doing is providing a tremendous service and help to the patient, and look at it from that point of view and not from the point of view that you're hurting the patient. So, okay, good morning. So, okay, this doesn't work with the space bar. Maybe I have to do that. So perceptions of phlebotomists, we get called vampires a lot. We're used to that. Sometimes it gets old. I will say we trained when our new building opened, when the K Jewelers Pavilion opened, we trained our newborn nurses how to do their own phlebotomy because we used to draw a newborn. And they have a whole new appreciation for what it takes to do phlebotomy now after having to be trained. So I'm just going to go through this real quick because we don't have a lot of time. We have a meeting at 10 o'clock. But the phlebotomist is the face of the lab. If you're clean and neat, they're going to think the lab is clean and neat. If you're a disorganized swab, they're going to think the lab is a disorganized area. They're going to, not trust you or the results that we're giving them because we are the face of the lab. So just, coming across as pleasant and knowledgeable and organized and confident goes a long way with your patient. Even if you're not confident, you have to appear confident and not let them see that you're nervous. If you don't label your blood in their presence, they're going to question their results. So just keep that in mind. Attitudes and fears and how to overcome them. So you want to approach your patient in a professional manner. Be calm and don't appear rushed, even if you are rushed. I know there's mornings, you might come in to draw a floor and you might have 10 draws and you're putting pressure on yourself to get them done and get back quickly, but you can't let your patient know that you're in a hurry. You want to make the patient feel important. Like that's the most important thing right now is when you're there with them, you want to give them all of your attention. You always want to greet them with a smile. You want to be neat, clean and neat and appropriately dressed and long hair, tie it back. I've done phlebotomy at times when my hair was longer and not tied back, and then it's like in your face like this, and you can't see what you're doing, which doesn't help matters any. Wear gloves that fit appropriately. That's really important because if your gloves are too big and the fingers are baggy at the end, you're going to have trouble feeling for that vein and palpating. And if you're doing a finger stick and you have the glove all bunched up, the blood's going to hit your glove and it's going to want to keep going there. So patient ID is extremely important. 1 in 18 errors causes an adverse patient event. And this data is kind of old, but about 6 years ago, there was 160,000 adverse events just because of mislabeled specimens. And lab tests determine 70% of a patient's healthcare decisions, including diagnosis and treatment. So it is really important. The results that we give are only as good as the specimen that is drawn. So if your specimen is not labeled properly, if it's a poor quality specimen because it's hemolyzed or it's clotted, then your results aren't going to be very good. And the doctors are counting on us to give diagnoses and patients to make decisions. And up to 70% of lab errors occur before the testing ever happens, with mislabeling, misprocessing, not following special instructions if something needs to be frozen for storage for testing, or We'll see stuff that needs to be whole blood that somebody accidentally spins down. So that pre-analytical phase is really important. Good morning. Good morning. Common mistakes in phlebotomy. One of the biggest ones is failure to confirm patient identification, specimen labeling errors, using the wrong tubes or filling them in the wrong order, quantity not sufficient, and failure to adhere to special requirements for testing. So those are the big mistakes in phlebotomy, those pre-analytical errors. And then when you're identifying your patient, acceptable identifiers are a full name, a date of birth, a hospital med rec number, and a photo ID in an outpatient setting. You never want to use a patient location or room number because that can change. You know, they move patients all the time. You don't want to go by a chart that's next to the bed. Had people do that before and they've gotten burned because it was an old chart from a patient that had been discharged. You don't want to go by a tag on the bed or a sign outside the door either, because there again, sometimes those don't get changed when patients leave. So inpatients should always have an armband that you should check, and you should always also confirm verbally as long as the patient is able to verbalize. You know, if you're drawing a patient in the PICU that's comatose, obviously they're not going to be able to answer your question, but there's usually a nurse or somebody nearby who confirm that identity. In emergency situations, when you don't know the name, every hospital is going to have its own policy that you'll follow. We use the last name of unknown here, and it gets registered as an unknown and assigned a medical record number so that we can do everything electronically in the system. So every hospital will have their own unique policy about that you will follow. And then in an outpatient setting, some places use armbands. We don't use them here. I think our outpatient radiology uses them, but we don't use them in lab. So we're just doing a verbal confirmation again. Moving forward. So I'll just run through this real quick. If a patient refuses to have their blood drawn, you have to honor their wish. If they tell you no, the answer is no. You notify the doctor or the nursing staff and you move on. If they're asking for information about what you're drawing or about their condition, refer them to their physician or to the nurse. We don't know about their condition. You guys are going to have a lot of knowledge and know why you're drawing the test, but the patient may not know the background, and you don't want to tell them like, oh, I'm drawing an AFP tumor marker if they don't know, you know, that the doctor's working them up for a suspected cancer diagnosis or whatever. I've had times where you're drawing a teenage girl for an HCG and mom's asking what you're drawing, and once they're 14 years old, their parents don't have to know about stuff like that. So you don't want to tell the mom, well, I'm drawing a pregnancy test if the mom doesn't know that, you know, so you got to be careful as far as that goes with answering questions. If a patient experiences a medical difficulty, you want to position them, you know, so they're comfortable and safe and call for help. Here at Children's, we dial 22 and we can call for either a first aid consult or a code blue. So every hospital is going to have their own policy on that stuff. And when you guys go out and do your phlebotomy rotation, they'll walk through that with you on how they handle that at their organization. There's a lot of times patients will want you to draw them in a certain site, and you might not feel comfortable with that. So just remember, you as the phlebotomist doing the draw are the expert, and you need to go where you're comfortable. So sometimes you have to explain things and gently redirect them so that you can do what you need to do. And the bottom one, we really don't get people asking about getting aids anymore from a phlebotomy, but when you're doing a draw, you should always open your equipment in front of your patient and let them see, you know, that you're using brand new things that have never been used before. So NACLS is now called CLSI, which is the Clinical and Laboratory Standards Institute. We are also governed by CAP. We at Children's are due for our CAP inspection. They come every 2 years and our window opens mid-December. So we are expecting them, probably not this year. Usually they don't come before Christmas because our window opens like December 17th. So we usually count on them more like in February, they show up. But both of these institutions set guidelines or best practices of what should be done to keep the phlebotomist safe and the patient safe in order to obtain a good blood specimen. There's also OSHA and CDC. So OSHA is the Occupational Safety and Health Administration. It's part of the U.S. Department of Labor, and then the Centers for Disease Control. And both of these organizations regulate safety. So patient isolation is one thing that you'll have to take into account, God bless you, when you're drawing in patients. There are a couple different kinds of isolation. There's contact isolation, which is just spread, like it says, by contact, by touching. Some of those things would be MRSA, VRE, C. diff. And so you gown and glove before you enter the room for patients like this. Droplet precautions is when the disease is spread by tiny droplets. And that would be things like pneumonia, influenza, whooping cough, meningitis. And so you wear a mask when you're going into the room. And then airborne precautions can float in the air. They can stay there for a long time. They can travel long distances. And that would be stuff like TB, measles, and chickenpox. So for those, you're going to wear an N95 mask or a respirator mask. And those patients are usually in a negative pressure room where you would enter through a little ante-room to get into the room. Donning your PPE. So the appropriate order to put PPE on is your gown, and then your mask or your respirator, then your goggles or your face shield, and then gloves. And then when you go to take your PPE off, you want to make sure that you're not contaminating yourself. So you first remove your gloves and you kind of peel them off and back and kind of ball them up inside of each other. Use your finger to kind of slide it back because you don't want to get anything from one glove onto your skin after you've pulled that glove off. And then you remove your goggles or your face shield, and then your gown, and then your mask or respirator. And I don't know, did they let you guys do anything with the glow germ?
No.
Okay, did you guys practice putting PPE on and taking it off with glow germ? Okay. Yeah, that's kind of cool sometimes to do and see. Before we had glow germ, we used to use chocolate syrup, which was really fun. So some precautions when you're drawing in the burn ward, obviously you want to avoid burned areas. Sometimes in the burn ward, we have to stick our feet and toes. So toe sticks are sometimes disgusting, as toes can be very calloused. In the ICU, we have to watch for the volume of blood that we're drawing. They can develop iatrogenic anemia, which is an anemia caused just by drawing too much blood. So they do have to watch that on hospitalized patients. And then on psychiatric patients, they need to be closely supervised. Everything you take into the room needs to come out of the room with you because they could use anything you leave to harm themselves or to harm somebody else. We don't use Coband on psych patients. The only thing we leave is the Band-Aid that we put on their arm. And here at Children's, we have somebody from our psych unit staff with us when we're drawing up there. I don't know how other hospitals handle that, but any questions so far? I know this stuff is not terribly exciting.
So for the patient identifiers, do you have to require a name? Like the name is a name, one of those things you absolutely have to, or could it just be like at any set, like a only two?
I would always do a name, especially verbally. And then your second one would be a date of birth or a med rec number.
Cool.
But I always do a name. Audrey?
When we go up to the 8th floor, they always tell us to go by last name instead of first name, just in case
Yeah.
they're changing the pronouns or their names and stuff like that. Is that still apply in these situations? Just go by
Yeah.
like legal last name?
Yeah. If you're in an outpatient setting, we always do first name too, because outpatient, we can have multiple people with the same last name, but that's one of the things now that we have to be very sensitive about as patients that are undergoing gender therapy treatment. And so you have to watch pronouns and how you refer to people, and we may have, a boy whose legal name is Chase, but they are undergoing hormone treatment and they're going by Cassie. So we have to be very careful of that because sometimes those patients get offended very easily, even though you're not meaning to offend them. I mean, you're looking at your labels, sometimes you're looking at them and, they look like a man, but they see themselves and are relating as a female. So that's, when I started here 30 years ago, that's not something we ever had to worry about, but it's something now that we have to be very cognizant of so that you don't offend somebody. So legal responsibilities for phlebotomy, the organization has to be able to prove that staff is trained. So we do an initial training checklist, and then we do competencies after that. Staff need to read policies. We need to make sure that we're following policies, because if you start deviating from those policies and somebody gets hurt, then your organization could be in really big trouble. And there have been lawsuits because of improper phlebotomy. So some general phlebotomy guidelines that we'll just go through real quick. Body substance precautions apply for all I can talk this morning. Specimen collection and transport procedures. You always want to wash your hands before and after. You can Purell if your hands aren't visibly soiled. But make sure too that your patient sees you washing their hands, because that's important to them so that they know you are doing that. I have had times where I've been in the hospital with family members, and if I don't see them washing their hands, I will speak up and ask them to do it. So hopefully, that's something patients and families should be paying attention to. Identify the patient as per the hospital's policy. All of our policies are on KidsNet. You also want to be careful not to place your collection supplies in the patient's bed. I've done this before, and then your patient kicks and your stuff just goes everywhere. And it's not very fun when you have a screaming child that you're trying to draw blood on and you've lost all your stuff and you have to stop what you're doing and regather everything. You always want to label your specimens with 2 identifiers, just like you're identifying your patient with 2 identifiers. You always want 2 identifiers on your specimen. And there again, that's name, med rec number, date of birth. We also can use an accession number as a unique identifier because each accession number is only used once. Used lancets, needles, and butterflies and syringes all get disposed of in a sharps container, even though everything now is safety engineered and the needle retracts, but we still put it in sharps. And then specimens should be packaged according to the hospital's transport policy and pneumatic tube system policy. So that's something when you're out at the sites that they should go over with you. And one other big thing, when you have to transport on ice, put your ice in a separate bag. It's awful when you get a tube with a wet, soggy label floating around in a bag of wet ice. And sometimes it makes the labels fall off and then you have an unlabeled specimen. So any questions?
Yeah, so obviously this is the deal, but could you just like with a Sharpie or even like put a small piece of paper on the tube, just put like name and date of birth? Will that work in here or?
We can use a label and just handwrite a label with name and date of birth, yes. I mean, ideally, you're gonna have a pre-printed label so that you don't misspell a patient's name.
So I have cases at least, I assume as ED, where every so often they like mess up the name somewhere when it comes to registration, so.
Yeah,
Okay.
Spot that's like blank, right? Paper, not a tube, just-
yeah. Unless you're, the micro tubes are hard to, like, you can't really write on a micro tube. You've got to get a blank patient label. But you never want to draw a tube of blood and not label it, set it down and not label it somehow. So some pre-phlebotomy guidelines. You want to start out by reviewing your orders, figuring out how much blood you're going to need and what tubes you need. And then you want to identify your patient. And then you're going to determine the best method to do your draw. Some things you're going to take into account are the age of the patient, the amount of blood you need, what tests are ordered, and the physical condition of the patient. And then you want to position the patient so that they are safe. And if they pass out on you, I had somebody about 2 weeks ago try to draw somebody in one of our outpatient labs who was standing up. Not safe, should never be done, because if that patient had passed out, we would have had a big problem on our hands. I mean, they could have hit their head and really injured themselves. And this was an autistic patient who didn't want to sit down, so she was trying to be accommodating. But you can only be accommodating so far, and you have to be able to keep your patient safe as well. So venopunctures, the recommended sites, I would be able to label some of the stuff in this diagram, at least the main veins. The median cubital vein is your vein that's right here in the anacube. And then the cephalic vein is the one that's outside here on your thumb side. And then your basilic is over here on your pinky side. So we try to always do the median when we can. The cephalic vein on the thumb side tends to roll, so you really have to anchor that one well. And the basilic vein is very close to the basilic artery and a nerve, the median nerve. So you have to be very careful there not to hit either one of those. There's some other things to keep in mind when you're drawing. You obviously don't want to stick in the middle of a rash, burn, or a hematoma or big bruise. You want to feel for the best vein. It'll feel like an elastic tube that kind of gives. And I tell people, tie a tourniquet on somebody and close your eyes and practice feeling with your eyes closed. And learn what that feel is like, because it'll kind of be a springy like bounce that you'll feel. And if you can get used to doing that with your eyes closed and find the vein, it will help you, because you're not always going to be able to see it. Like, I have huge veins that you can see from across the room. I let the students practice on me, and I'm an easy stick, but you're not always going to be able to see it, and you need to learn to feel it and not just go by what you can see. And that takes a while to develop the confidence to do that. If you feel a pulse, it is an artery and not a vein, so you don't want to stick it. You never want to draw above an IV, because what are you getting if you draw above an IV? Yeah, you're just getting the IV fluid. So, if your patient's getting glucose and you're drawing above the IV, you're going to have a sky-high glucose. You want to draw from below a hematoma. You don't ever want to draw from above a hematoma. If you have a patient that has thromboses, or they have clotting issues, you don't want to draw from a vein that feels hard and cord-like. You want to feel that elasticy kind of give when you push on it. And if both hands or both arms are injured, then you're looking at hands, or sometimes, like I said in our burn ward, you're looking at feet or ankles or toes. Another couple others that are on the chart there for mastectomy, that's not something we ever usually have to deal with here at Children's, but usually when a patient has a mastectomy, they're also taking lymph nodes, so you want to avoid sticking on that side. You would use the other arm. And if a patient has had a double mastectomy, then you talk to them about which side is better to draw, because you want to do the side that had less lymph nodes removed, and usually they will know that. If a patient has a fistula or a shunt, like for dialysis, you want to stay away from that arm and do the other arm, because you don't want to do anything to mess that shunt up or that cannula, because those are surgically inserted and we just want to stay away from those. So positioning your patient, you want the vein to be accessible to you. You don't want to have to be a contortionist trying to, twist around to get where you're comfortable to draw them. You want the patient to be comfortable and supported if they would pass out. And you want some support under their arm, especially in peds patients who can't sit still. So sometimes even if they're an inpatient in bed, putting a pillow under their arm or rolling up a blanket, putting it under there sometimes helps you, because they will bend and move. Sometimes that you would have to use veins outside of the antecubital area would be if the patient has a cast, an IV, bruises, rashes, burns. Some patients that are hospitalized for a long period of time, you can tell their arm just looks very sore just by the way it looks. You can tell it's been stuck a lot, so you want to try to stay away from that area. Or if the veins are thrombosed. So some of the alternate sites, like I said earlier, are hand, wrist, ankle, or foot. You need to be careful when you're sticking in those areas, because the veins are smaller, they're closer to arteries, they're closer to nerves and tendons, and you don't want to hit one of those. Our NICU will sometimes do veins in the head. You'll even see babies in NICU with IVs in the head. Fortunately, we don't ever have to do that. Sometimes they'll also do an arterial stick, especially I've seen them do it a few times on a trauma where you have a trauma come in that's really bad and they're crashing, and they'll just do a femoral stick to get the volume of blood that they need very quickly. And then respiratory care will do arterial sticks for blood gases, and those they frequently do in the wrist. Any questions up to this point? Okay, then we'll start going through the steps of the venipuncture. So the first thing you're going to do is select your proper size needle and attach it to your syringe or your vacutainer. So here at Children's, we draw pretty much exclusively with butterflies. They're less scary for the kids. They let us control the pressure instead of a vacutainer, which the vacuum in the tube controls your pressure. And the kids just think they're less scary looking than the big vacutainer needles. So if you're using a syringe, you want to pull back on the plunger so that the plunger is moving freely. And then you want to position the draw site so that you can have a good angle and feel comfortable. The tourniquet goes on 3 to 4 inches above where you're going to draw. And my understanding is you guys are going to do a lab practicing tying tourniquets done with the lecture today. So take those home with you, practice tying them on your family members, and then closing your eyes and feeling for those veins. And it will help you a lot. So the rule of thumb is you never leave a tourniquet on for more than 1 minute. You'll instruct your patient to make a fist and hold it. You don't want them to pump. Sometimes you'll see people doing this, and that can cause hemoconcentration of your specimen, so you don't want to do that. We use a chlorhexidine wipe here, which is just an alcohol wipe with some chlorhexidine in it. Some sites would use alcohol. You always want to allow it to air dry. You don't want to blow on it. You don't want to take gauze and dry it off, because then you're just contaminating the site again. So if you accidentally touch the site after you clean it, you should re-clean it. And then you want to grasp the patient's arm and use your thumb to anchor the vein. You don't want to anchor like this, because if your needle slips, what's going to happen? So you're going to stick yourself. So you want to be careful. I can't I can't do this on myself, but you want to keep this finger kind of to the side and pull to the side. You don't want to curl it and have it be directly above where you're sticking that needle in. And then the needle should go in bevel side up. I had somebody stick me once bevel side down. It does not feel good. It hurts a lot more. And you need to go at a 15 to 30 degree angle into the vein. If your patient complains of a shooting electric-like pain, you need to remove the needle immediately because it's possible that you hit a nerve. And do the venipuncture again in another site. And if you ever, anytime you have an issue with phlebotomy, if you think you've hit an artery or you think you've hit a nerve, you should let the nursing floor know or let the provider, the ordering physician know, and also document that. Here at Children's, we have a system called MIDAS that we use for all of our documentation of incidents, but you want to have a record of what happened and have good documentation in case that patient complains or there, ends up being an issue. If you hit an artery, you're going to see a pulsing flow of bright red blood. You really don't need to be real afraid about hitting an artery. I've been doing phlebotomy for 30 years and I've never hit an artery. I mean, your chances of doing it are very slim, but you should know what to do just in case. When you hit an artery, it takes a lot longer to stop bleeding than a vein does. So you need to apply pressure for at least 5 minutes or until the bleeding stops. And then, you want to notify the nurse so that they can keep an eye on the patient and make sure it doesn't start bleeding again. So what happens if your blood doesn't begin to flow? It could be that you went through the vein. It could be the angle that you're in, like that the bevel is up against the edge or the side of the vein. So you might need to just change your angle on the needle a little bit. What you don't want to do is what we call probing, which is when you see people just start pulling the needle and just digging everywhere. You can feel and pull back and a little bit and then reinsert a little bit, changing your direction based on where you feel that vein to be. But you should never, we call it digging or excessive probing, where you're just basically trying blindly to pick up the vein. And I've seen a lot of people do it. I've seen doctors do it. But it is not good practice, and it's a good way to injure your patient and also end up with a bad specimen if you do end up getting it. The rule of thumb for any organization, this is kind of CLSI guidelines, is that you make 2 attempts, and if you can't get it, then you have somebody else try sticking. So here we have a person try twice. They will come back to the lab and have somebody else go try twice. And then if they can't get it, then we leave it for nursing to draw. So once your collection is complete, you're going to take the tourniquet off, put a piece of gauze over the site, and then activate your safety device on your needle to retract the needle. And then you can apply your Band-Aid or your Coflex. So the order of draw is very important, and I'm pretty sure you guys talked about the different tubes in the anticoagulants when you did chemistry, right? So you don't want to have that carry, you want to watch the carryover of anticoagulants so that it doesn't affect your results. So that's just the order of draw with the most common tubes. There is now also, like, we have a TAM EDTA tube, we have a dark blue EDTA tube that are for trace metals. So there are a lot more different colors of tubes now. So the Vacutainer system is a double pointed needle with a plastic holder adapter and then your series of tubes with rubber stoppers. And most of the adult hospitals use Vacutainers. The butterflies they give them, a lot of times they may only let them use a box of butterflies a month, or they they ration those butterflies out because they're expensive, so. Probably most of you guys, when you're doing your phlebotomy, most of what you're doing will be vacutainer draws. And the vacuum in that tube is what is controlling this flow of blood from the vein. So that's why we don't use them here at Children's, because a lot of our kids, their veins are so small that if we used a vacutainer tube, it could collapse their vein. And when we're using a syringe, we can pull back slowly and control that pressure. There are some advantages and disadvantages to both. A vacutainer is a closed system, so you're not going to get blood on yourself. A needle and syringe obviously is an open system. I have seen people pull the plunger out of the back of the syringe, and that creates a real mess. The vacutainer, the pressure is set versus a needle and a syringe, you're controlling it. It's harder to reposition with a vacutainer. And it can cause tissue damage if you try to reposition too much. It's easier to reposition with a butterfly. With a butterfly, your tubing, you get a little flash of blood when you're in the vein. In the vacutainer, you really don't know if you're in the vein. With the vacutainer, you put the needle in and then you pop your tube on after you think it's in the vein. So it's nice having a little flash of blood in your butterfly just to confirm that you are indeed in the vein. You have to be careful with a vacutainer when you're changing the tubes that you anchor it well and don't accidentally push the needle in farther when you're changing those tubes. And then the vacutainer system is cheaper than the butterflies. Any questions about that? So the needle gauge is the diameter of the needle, and the smaller the number, then the larger the needle. So when you're donating blood, they tend to use a 16 or a 17 gauge needle. Most of our phlebotomy, we're using a 21 gauge needle. We also have 23s and we have 25s. We use the 23s some on younger children and babies, and the 25s pretty much just on babies. You have to be careful because the smaller the bore of the needle you go, the more chance you have of hemolyzing your specimen as it's going into your syringe or into your vacuum tube. It's just a smaller area for those red cells to flow through. So if it's flowing too quickly, it can lyse those red cells and you have hemolysis. So you always want to use the biggest needle you can for your patient. Our outpatient lab uses almost exclusively 21s. A box of 23s can last them for months. Our CCL tends to use a lot more 23s than our outpatient lab does. Just get in the habit of trying to use a 21 if you can, because it's better to get a better specimen type. There's also some differences in the length of the needles. Needles can be 1 or 1.5 inches. Sometimes you need a 1.5 inch needle just to get to a person's vein if they have a very big arm. A 1 inch needle might not be big enough. We're dealing with pediatric patients here, so obviously the smaller the needle that we're coming at them with, the better off we are, just because they see the size of it and they want to know if the whole thing is going to go into their arm. So that's another thing that's really important, to explain what you're doing to your patient as you're doing it, so they're not surprised. Especially with pediatrics, where it could be their first draw and you're kind of setting the tone for future draws. So you want to take the time and explain everything you're doing and answer their questions so that they're not afraid. Different gauge sizes for different size veins. And then the butterflies are good for difficult venipunctures. The butterflies have wings on them that you fold them up, and it makes it easier to manipulate the needle. So hemoconcentration is when you have more cellular elements than plasma. And there are a couple causes for this. If the tourniquet is on too tightly or more than 1 minute, it can cause it. If you're hitting or slapping, sometimes you see people doing that, trying to get the vein to pop up, but that can cause hemoconcentration. Excessive probing or that digging, having them pump their fist if they have hardened or blocked veins. And then one of the ways that we see it a lot, especially it seems like with our heme patients, is if you draw off a line and you set your syringe down on the counter, and then you flush your line and your syringe sits there for a minute before you fill your tubes. And some of those kids, like their red cells precipitate out very quickly. And if they don't mix that syringe up again before they fill their tubes, you can end up with hemoconcentrated specimens. So we really watch when we have line draws. You know, if you have a kid that has a hemoglobin of 12 and then the next day their hemoglobin is a 6, you have to question whether that's a hemoconcentrated specimen and that you ended up with most of the plasma and maybe the green top ended up with most of the red cells. And hemoconcentration affects a lot of the chemistries. It affects the albumin, ammonia, billy, calcium, all your enzymes, iron, lactic acid, lipids. Hematology, it affects your red cell counts, which then affects your H and H. So disposal of phlebotomy equipment. Your needles, you want to immediately use the safety device on them and then discard them in a sharps container. You never want to recap a needle, although I think in this day and age, you probably, for the most part, would have trouble finding a needle that you can recap. Although if they're doing like a synovial fluid tap or something like that, like they're still using regular needles, but the phlebotomy needles anymore all have a retractable, a button that you push to retract them, or some of them you would slide. There's a piece that slides or folds up over the needle to protect you. And the lancets that we use now, you hit the button, it sticks, it retracts. If your gauze is dripping with blood, then it should be treated as a biohazard and go into a biohazard container. But if it's just, you know, blood from wiping up the site or not completely dripping, then it can go in the regular garbage. Any questions? So some possible negative effects due to a venipuncture, the patient can develop a hematoma, which is caused when blood leaks into the tissue around the venipuncture site. Some things that can cause that are not removing the tourniquet before you remove the needle. You always want to untie your tourniquet and then pull the needle out. Not applying proper pressure after you've removed the needle. If you've only partially penetrated the vein or you've gone all the way through the vein, it can allow blood to leak out to cause a hematoma. You also don't want to have a patient bend their arm after you pull the needle out to apply pressure. Like you want them to hold their arm out straight and have them apply pressure for a couple minutes. Using too big of a needle can cause a hematoma, and then excessive probing, obviously. It is possible to hit a tendon or a muscle that can cause a small knot in that tendon or muscle that will last for a couple of days, and it can be painful. So you want to avoid excessive probing and make sure you're entering the vein at the proper angle, and that will help keep you from doing that. Sometimes patients get post-phlebotomy bleeding, which can cause just surface bruising. And then it's rare, but if you hit a nerve, you can cause nerve injury. This can be done by improper vein selection where you're too close to the nerve. Sometimes your patient will jerk, or maybe you'll jerk as you're inserting the needle, and blind probing. When you can't feel that vein and don't know exactly where you're trying to go, you can also end up hitting a nerve. So arteries versus veins, the arteries tend to be deeper. Arteries have a pulse and the blood travels in spurts. The arterial blood is brighter red because it still has the oxygen. An artery is preferred over a vein on a respiratory patient if they're wanting to get blood gases to have accurate gases with the oxygen and CO2 levels. Sometimes they'll also do arterial punctures on patients that are dehydrated, or like I said earlier, trauma patients where you can tend to get the blood quicker with an arterial stick. So specimen labeling, the label has to contain 2 unique patient identifiers. The Joint Commission requires that specimens be labeled in the presence of a patient at the bedside. And you always want to put a phlebotomist ID on the label so they know who drew it and the time. And then here at Children's, we also mark whether it's a venipuncture or a capillary draw. And then you just want to be careful putting your label on so that the information is legible and it's not all scrunched up and your label can't fall off. It's really great when you get one like that one on the end that they've also put in a bag of wet soggy ice and then your label falls off very easily. I've seen those fall off. If they're all scrunched up and not lined up nicely so that you have a lot of adhesive still sticking out, it just makes it harder to put it in the centrifuge and get it back out of the centrifuge. So you want to try to label your tubes neatly. And this was just a cute little poster I found on the worst dressed tubes. I like the little turtleneck one. That happens a lot too. And then it's hard to open your tube. So what happens when you can't obtain a specimen? And these things happen all the time. You go to the floor to draw your patient and they're not there. And then you tell the floor to call you when they come back and they never call you. So we usually have to call back and check, is your patient back? And go get them. Technically here at Children's, if a patient transfers to another unit, their orders are supposed to cancel and they're supposed to reorder what they want. But it's always a good idea if you know a patient has transferred to check before you draw them in case their orders have changed. Because a lot of times, like if we have a patient going from PICU to one of the patient floors, maybe they forgot to discontinue some of those orders, but they frequently don't need as much once they transfer out. And then, like we talked about earlier, if you can't obtain the blood, 2 tries. Make sure you keep nursing informed of what's going on. Communication is important. And let them know, I couldn't get this. I'm going to go down and have somebody else come up. Don't just disappear and have them wonder what's going on. Any questions about venipunctures? We will move on to capillary sticks. And I don't know how much chance you guys will get to do this in your rotation because you guys do most of your phlebotomy is it at Altman? Yeah. Okay. I don't know how many finger sticks they do. I don't know how much practice you guys will get at this. We do quite a few finger sticks here because of our pediatric population. So there are some times that you would choose a capillary stick over a venipuncture. If a patient has very fragile veins, if you've tried multiple times to do a venipuncture and can't get them, if a patient has burns or scarring, extremely obese patients, people that are getting drawn frequently, people that have IVs in both hands. That's awful when you go to a room to draw a patient and they have IVs in both hands. It's like, oh, it's not fun because it doesn't leave you much option. Patients at risk for serious complications with venipuncture, like somebody who has deep vein thrombosis, if you can get the blood from a finger instead of doing a venipuncture, you're better off. If you only need a small amount of blood, some of the kids that are here for long periods of time that are getting IVs and chemo, like they try to save their veins for those, because if they have an IV running, it'll only last so many days and then they have to move it somewhere else. So we try to save those veins. And then point of care testing where you only need a small drop of blood, like for a glucometer. Capillary blood sticks are not appropriate if your patient is severely dehydrated. You don't have good capillary flow when you're dehydrated. So you're not going to get a good specimen. Chances are you will have a hemolyzed specimen if the patient is really dehydrated. Same if a patient has really poor circulation. So some of like our heart patients, it's hard to get a finger stick just because their circulation is so poor. Coag studies always have to be a venipuncture unless you're doing a proton by monitor. And then tests that require a large volume of blood, like sed rates, blood cultures, can't be capillary. And then there are some tests like an ammonia that have to be venous. So that we do capillary heel sticks and capillary finger sticks. We routinely do fingers on patients that are over 6 months or adjusted age of 6 months. If your baby's been in the NICU, sometimes we can go a lot longer than that, you know, depending on their size. The heel should be done, if possible, for patients that are 6 months to 1 year, but you can do a finger over 6 months if you need to. Heels are routinely done on infants less than 6 months. And part of your decision when you're deciding is how big your hand is and can you hold that patient's heel. You know, you get an 8-month-old baby, some 8-month-old babies, I can't hardly get my hand around to be able to hold and squeeze, so. And then sometimes you'll do a toe like a burn patient because that may be the only skin that is exposed on them. Sometimes the quad patients will ask you to do a toe just because they won't feel it. So some factors associated with good blood flow for a capillary draw, the depth of the stick is important. The lancet controls that now. Back when I first started, we used like Bart Parker lancets that you controlled how far you poked in. And you could poke too deeply. It's kind of nice now that the lancet controls that for you and you don't have to worry about going too deeply. The site of the stick, you want to be in the middle of the capillary bed. So you don't want to like stick way down here on the finger. You want to kind of go out on the sides where the capillary bed is. Your squeezing technique is important. You kind of use a milking motion to kind of squeeze from the bottom up. So if you're squeezing improperly, you won't get good blood flow. The patient hematocrit contributes to this. The higher the crit, the slower it's going to flow usually. And you have to remember to draw more blood. I've seen times where we draw Billy babies in the NICU that have high H&Hs, and you might draw a completely full micro tube that'll hold like 600 microliters, and you're lucky to get 100 microliters of plasma off of it because their H&H is so high. So you kind of learn over time how to tell how thick it is and how much you need to draw to compensate for that. The skin temperature of the puncture site is important. Warmth increases the blood flow. The thickness of the skin. There are times when we're doing patients in burn ward, you know, that are older patients, and their skin is very calloused, and sometimes it's a lot harder to do a finger or a toe then, just because I once stuck a patient in burn ward that played guitar, and the ends of his fingers was all he had that weren't wrapped, and his fingers were so calloused from playing guitar, it was really hard to find a spot where I could get into a capillary bed to draw. So, and then you want to rest the puncture site. You might have heard of capillary refill time. But when you squeeze, you kind of have to stop for a second and let that blood flow back up and refill that capillary bed. And some patients you find you might have to like count to 5 in between squeezing, because if you just keep squeezing, you're not going to get anything. But if you wait a few seconds and let that capillary bed refill, then you'll be able to get another drop. So warming the capillary site really helps. It can increase the blood flow 7 times over normal if it's cold. It also arterializes the blood. And so if you're doing a capillary stick for a blood gas, you always want to warm the site. We have heel warmers that we use to warm. That controls the temperature for us because you don't want it to be above 42 degrees. You never want to put these in the microwave. I've heard of it happening at other sites and people getting burns because people have put these in the microwave to warm their patient. I've also seen people take gloves and fill them with hot water from the sink. I don't recommend that because all it takes is one tiny little pinprick and you have a mess. Diapers work really well to warm. If you just take the diaper, a clean diaper, and run it under warm water and then wrap that around. And it's nice because you can use the fasteners to fasten it on there and leave it for a couple minutes. You just got to be careful that the water's not too hot, like, one on your wrist to make sure it's not too hot. Oh, and I had that on my next slide. So a diaper saturated with warm water works. The site should be warmed for 3 to 5 minutes. If you wait longer than that, then it starts to cool down because those heel warmers don't stay warm for super long. Sometimes even just massaging the area, if you don't have a heel warmer or don't have access to warm water and some of these fingers are cold, sometimes if you just kind of sit there and massage their fingers for a minute before you stick them, it warms that area up and it makes a big difference. So the lancets that we use are all safety engineered. They're all single use. They control the depth for you and the width of the puncture. And the way the lancets are made, they don't exceed 2 to 2.5 millimeters deep for adults. They shouldn't be more than 2 millimeters for infants and children. And the width shouldn't be more than 2.2 millimeters. You want to pick a site where the bone is not close to the skin, because if you poke the bone, you can cause an infection called osteomyelitis. And you want to select an area that's not callous, bruised, swollen, cyanotic, cold, or infected. And sometimes it's hard to avoid previous puncture sites, because if you have a patient that's in the hospital for days and they're getting stuck multiple times a day, sometimes it's a challenge just to find a spot to stick them. And then, you look at their fingers and say, okay, which finger do you want me to do? Because they'll tell you the one that hurts the least. Generally, these are the 2 fingers we do, the middle finger and the ring finger. Those tend to give the best blood flow. So this is just an example of some of the lancets. This is our primary finger lancet that we use. You should, in theory, be able to obtain 2 to 2.5 mils of blood using one of these, which will fill like 4 microtubes. Then we have a purple lancet. It doesn't poke as deeply, and we use this if we're just needing a drop of blood, like for a glucometer. Or sometimes we'll have a patient that just bleeds really, really well, and that you can use a purple instead of a blue, if you're sticking them often. And then heel lancets look something like this. There are multiple sizes based on the size of the baby. So a full-term baby or a normal size baby greater than 1.5 kilos, we would use this, which 1.5 kilos is about 3.3 pounds. Smaller babies that are like between 2 and 3.3 pounds, we would use this preemie lancet so it doesn't poke quite as deeply. And then we have a unistick lancet that we use we term them micro preemies. And these are babies that are less than 1,000 grams or about 2 pounds or less. We could use these lancets. I loved drawing in NICU. That was my favorite place to draw. And I was so disappointed when I had to train them to do their own draws and we don't go over there anymore. So the tubes and the anticoagulants, we do draw cap gases here. I'm not sure that any of the adult hospitals would do this, but we have the little plastic gas tubes and those are a sodium heparin tube. There's a technique to drawing them because it's really easy to get air bubbles in them. And obviously, if you're doing a blood gas, an air bubble is not a good thing because that's going to falsely increase your oxygen or your CO2 and decrease your oxygen. We put a little metal flea in there that you can see on the bottom, and then we use a magnet to just mix it so it doesn't clot. If you don't have a magnet, just kind of rock it back and forth so that that flea mixes the specimen. We sometimes also use cap gas tubes to do karyotypes because karyotype testing, fish testing is done on sodium heparin. So sometimes if we have a baby in the NICU that they can't get a venipuncture on, they'll use the capillary gas tubes for that. The EDTA tubes we use for CBCs, hemograms, platelets, retics. We can use a microtube for an pneumonia, but an pneumonia has to be a venipuncture or come from an art line. We can't do a capillary stick. But volume-wise, we don't need much blood. So if somebody draws an pneumonia by venipuncture, they can put it into a microtube and we can run it. We have dark greens that don't have gel in them. We use these for ionized calciums like whole blood sodium, potassium chloride that get run on our gas analyzers. We also can do a lactic acid whole blood on the gas analyzer. So anytime you're running a test on a gas analyzer, you don't want to use a tube that has gel. The gas analyzer is not at all happy if you accidentally sip up some of that gel instead of blood. And then the light green with gel, we do all of our chemistries here at Children's using gel tubes. So using heparin gel tubes, a lot of the adult hospitals use red tops. So, you know, it's going to depend on the instrumentation they have and what they have validated for specimen types. We use the plasma for most everything, but there are a lot of things that we can use, you know, EDTA plasma, or we can use serum. Just not our preferred specimen type. And then there is also a micro clot tube. One thing with clot tubes, we had an issue a few years ago with our infusion clinic, and they draw a lot of aldolaces, and aldolaces can't be hemolyzed. If it's hemolyzed, you get falsely elevated results. So we cancel them. And they had a very high rate of hemolysis on aldolaces, and we couldn't figure out why. And then we discovered they were walking to the lab, mixing their red tops so that they wouldn't clot. A red top is supposed to clot. And by mixing it, when it's trying to clot, they were lysing the red cells. So a lot of clot tubes now have a clot activator that as soon as you draw it, you want to mix it a few times to get that clot activator going. But if you mix a red top that's trying to clot, you're going to hemolyze it and you're going to have a bad specimen. So once we figured out what they were doing, and it was just by chance that we saw them walk into the lab mixing it, we're like, do you guys do that all the time when you're bringing those over? And they're like, yeah. It's like, oh, that's the problem. Like, we spent weeks, we went over and watched them draw, carried the specimen back with us. You know, we couldn't figure out what they were doing to cause this hemolysis. So the order of draw for a capillary stick is different than for a venipuncture. You kind of go by the order that you don't want things to clot. You don't have to worry about carryover of anticoagulant since you're just filling the tubes directly with your drops. So you do your cap gas tubes first, then you do your EDTA for your CBC, then your heparin tubes, and then your clot tubes. And then if you have to draw a newborn screen, you would do that last. Any questions so far? I'm sorry, this material is not terribly exciting, but it's important that you have the background knowledge before you show up to stick your first person. So we'll go through the procedure then for doing a finger stick. So you want to select a site in the colored area there. That's where the capillary bed is the best. You want to clean your site, and same with a venipuncture. You don't want to wipe it dry. You don't want to blow it dry. It's really important with finger sticks, though, that the site be dry, because if it's not dry, instead of forming a nice drop of blood, it's just going to run everywhere that it's wet. And when that happens, it tends to hit your glove. And then once it hits your glove, it wants to keep hitting your glove. And then you're fighting this battle where you're taking gauze and wiping your glove dry and wiping the site. And it's very frustrating. So you always want to make sure your capillary site is very dry before you stick. Then you'll use your lancet to make your poke. You want to squeeze firm enough that you're kind of milking the finger and moving that blood down, but you want to avoid excessive pressure. If you squeeze too hard, you're going to hemolyze the specimen, and you're also squeezing tissue fluid into the drop of blood. The tubes have a little scoop at the end. The scoop is not to scoop. The scoop is to let the drop of blood hit it and run down in. So you don't want to like scrape the site to try to get your blood. You want nice free flowing drops. When it's full, you cap it and mix it 5 to 10 times. Band-Aid when you're done. We have a policy here at Children's that we don't put Band-Aids on children under 3 because it's a choking risk. If there is a parent in the room, we can ask if they want a Band-Aid, and then we remind them to keep a close eye on the child because we don't want them to choke, and ask them to take it off in 10 or 15 minutes. And then, of course, you want to label the specimen before you leave the bedside. Heel sticks are similar. That's the area of the heel you're going to go in. If you go in that middle part between the guesses, the bone is very close to the surface there, and you could hit bone. So you want to stay out on those fleshy outsides. You'll clean the site just like for a finger stick, and then do your poke. Your lancet can either be like that, or you can turn it 90 degrees in that area. You have to watch with heel lancets because they tend to slide a little bit as you're pushing down on the button. So you have to be really careful to kind of use your 2 fingers to anchor it well and then push down. If it slides, sometimes you're not poking them quite in the area you wanted to, and you might not get as good a blood flow. When you're doing a capillary stick, you always want to wipe away the first drop of blood because it can be contaminated with tissue fluid. And that's especially important if you're doing like a glucometer where you only need 1 drop of blood. You don't want to have a contaminated drop. When you're doing a heel stick, you kind of make a C with your hand and wrap it around their foot. And then you squeeze like this. And then like in our NICU, and even sometimes the smaller babies on the floor, their skin is really sensitive, and we don't want to put a Band-Aid on it because it can pull the skin off when they remove the Band-Aid. So we'll use a piece of gauze and just tie it around the foot. And some of our babies in NICU, you know, their feet are like that big. So a piece of gauze just completely covers their foot. The state metabolic screen, did you guys talk about this when you did chemistry at all?
Yeah.
A little bit, okay. So, it is mandated, it is a law in the state of Ohio that every baby have a state screen drawn. A parent can opt out of it for religious reasons, but they have to sign a form to do that. The screen is supposed to be drawn after they're 24 hours old, but before they're 5 days old. I think our screen now covers 40-some disorders. They keep adding things. It allows for early diagnosis and treatment using a very small drop of blood. So the state screen card has the 5 little circles. Each circle holds about 100 microliters. So with a half a mil of blood, you're screening for all of those things. It is very cost effective. The cost just went up this year. The state used to charge us 70, it was like $76 and some odd cents for a card. It went up this year to just under 100, but still for $100 when you're screening, bless you, for all of those tests, it's a really good deal. It is just a screen, so any abnormal results do require confirmatory testing. I am the hospital's newborn state screening coordinator, so I have to keep track of all the abnormals and I have to make sure that that confirmation testing is done and notify the ODH. It's something that they do monitor. There are a lot of diseases that it covers, amino acid disorders like argynemia. You guys have probably heard of homocystinuria, maple syrup urine disease, PKU, and tyrosinemia. It does some endocrine disorders such as congenital adrenal hyperplasia. That would be a 17-hydroxyprogesterone. And then the hypothyroid, they do a TSH, and then if the TSH is abnormal, they'll do a T4. It does a lot of fatty acid disorders. Those are listed there. Organic acid disorders. It also does biotinidase deficiency. It does an immunoreactive trypsinogen for cystic fibrosis, galactose for galactosemia. It does T cell receptors for severe combined immunodeficiency. It screens for sickle cell disease and other hemoglobinopathies. So you really get a bang for your buck out of this test. They also will use a newborn state screen sometimes for foreign adoptions, because when you have a child coming into the country that you don't really have much medical history on, it's a good screening just to pick up if there's any problems. The ODH only has reference ranges up to 1 year old. So when we have, international adoptions up to 1 year, we'll send them to the ODH, and then there's a lab in Pennsylvania called PerkinElmer that we can send them to if they're over 1 to do that screening. So this is a picture of what the card looks like. The front side, they fill in all the baby's information with like name, sex, date of birth, time of birth, weight. We have to let them know what feeds the baby's on, because if they're on TPN, babies that are on TPN usually have an abnormal amino acid just because of the TPN that they're on. So they'll repeat that when they're off of TPN. And usually it's normal. But the normal ranges are based on the weight and the gestational age. So and it's very easy to mislabel these, especially when they have twins. So sometimes people forget that this is still a blood specimen and you need to check 2 identifiers. So this has 5 little filter paper circles, and you just gently touch the circle to the drop of blood and let it like seep into the filter paper. You don't want to push down on it, and like scrape it against it. What they do then is they use a little hole punch, and they can punch 3 little circles out of each of those bigger circles. And then they elute those in saline to be able to do the testing, so. You want to avoid layering or blood clots. Sometimes they're really nasty looking. It's really important on the state screen card that there not be any anticoagulant in the sample, but some of the testing is very sensitive, so in newborn, they try not to even draw them off a line because they don't want any heparin contamination. They usually stick. So sometimes we'll use just the scoop of a red top to collect a couple drops and then tip it if we're having trouble getting the screen. And we have, we call those Barbie basters. I don't like those. I end up with bubbles and I don't get good drops of blood, but. So the blood has to soak completely through the circle to the back side so that both sides should look the same. And you don't want to have layering or insufficient. You know, sometimes the front side looks great and then you turn it over on the back and like it hasn't soaked through at all. So we allow these to dry for 3 hours. We send these to the state and then usually takes about 10 days and we get results back. The other special capillary test is capillary blood gases. Molly, you just got signed off on these, right? Okay. They're a challenge until you get used to doing it because you've got this skinny little plastic tube that you're trying not to get full of air bubbles so that you can run your gas. So you get a drop of blood and you put your tube in at an angle and then you lower it so that it'll fill and then you pull it away and you kind of have to tip it back up and you squeeze and get another drop of blood and you keep repeating that until you have your tube filled. You don't want to collect from drops of blood that are just dripping down the foot because that blood has been exposed to the air and it's going to affect your gas levels. And then like I showed you the picture before, we put the little fleas in and we use a magnet to mix it. A capillary gas is most comparable to an arterial gas. It does give them a pretty good estimate of the oxygen level as compared to an ERT specimen. So and it's much easier than putting a patient through an arterial stick, which is painful. So blood gases, we just put them in little tubes like that for transport and label those tubes because otherwise it's really hard to label the gas tube. I need to update this slide because we stopped sending gases on ice now. They are now stable for a half hour at room temperature. We talked a little bit about iatrogenic anemia earlier. So some hospitals will document the amount of blood that is drawn. It used to be in our NICU that they had a little quarter sheet of paper on the end of each isolate that we put the date and how much we drew and then a running total of what we drew. We stopped doing that, but some institutions do still do that just to keep an eye out. We have a maximum allowable blood draw policy here at Children's, trying to be cognizant of that so that we don't draw too much. So on outpatients, basically our policy says whatever the baby's weight is in kilos, we can draw 2 mils of blood for every kilo they weigh. And once we hit that maximum, we have to wait 72 hours before we stick them again. So there are times, you know, if we have a baby that's getting a transplant workup that's coming into outpatient to get all those labs drawn, where they may have to come back a couple times, 3 days apart to get everything drawn, so we can get that done. They tend not to worry about it so much inpatient. If we're drawing the patient, we watch it. Nursing doesn't really pay much attention to it, but if we're drawing an inpatient that we need to exceed the maximum volume, we have to talk to the doctor and they have to document and put an order in the chart. to exceed that maximum volume. There's also a product that they use, especially in the NICU and up on the infant floor, called Sweeties. It's a 24% sucrose and water solution, and it has been shown to statistically to reduce the discomfort in infants. You can see there's like a little squeeze ampule that you can just put it under their tongue, where they have the little cups that sometimes they'll just dip their binky in it and then stick that in their mouth. And it really is, the sugar is calming to them and helps them get through the process. You'll find when you're doing newborns, they don't like you squeezing their foot. It's uncomfortable. So if they have that Sweeties, a lot of times it helps. And that was the last slide. So